today we are going to have a very challenging topic for all of us clinically, the diagnosis of non-XLH FGF23 disorders. And that's a real toughie. And so we are particularly thrilled to have Dr. Sherri-Ann Burnett-Bowie from the MGH in Boston talk to us about that today. I think we're going to have a grand session. We will, as Michael pointed out, have the main presentation. We'll take a little break right at that point to answer any question you have on the main talk. And then she's got two great cases to test us all with and challenge us all with. So welcome back. And Dr. Burnett-Bowie, thank you so much for joining us today.
Thank you so much, Dr. Tosi, to you and the incredible team. And thank you to all of my colleagues who are here today. I'm going to go ahead and share my screen. And so for the first section, which I'm hoping I have my timer on, so if you see me looking down, that's why, to cover in about 40 minutes. First, in terms of my disclosures, I served as the safety officer for one of the really novel trials that Dr. Ekons has performed, and which has been published in terms of use of iron therapy for patients with autosomal dominant hypophosphatemic rickets. So today, I'm going to briefly review phosphate physiology, as that is very relevant to why we test and why we evaluate in the way that we do when we suspect a patient of having a FGF23 mediated disorder, and then go through some of the, again, the details of that evaluation. In our second session, a lot of those details will really come to life in the discussion of the two patients. So as a reminder, our bodies are really replete with phosphate, but the majority of that phosphate is in the bone phase, and really a minority, less than 0.3%, that's in circulation. When you think about sort of this physiology, it makes sense that if you really have renal phosphate wasting, why there's such a significant bone phenotype associated. And similarly, why whenever I'm on our internal medicine service, I always remind that for someone who's truly phosphate deplete, the need for more than 3 days of phosphate repletion. Oftentimes when we do that in inpatient patients who are on the inpatient service, we're likely treating some brief intracellular shifts as opposed to true profound hypophosphatemia. There is a diurnal variation in phosphate, as well as it being influenced by meals and age. So for those of you who see children, this normal range is actually maybe still that may not capture what is actually normal for children. This is the closer to the adult normal range, but because of the influence of time and meals, most labs have the lower limit of normal as 2.5 milligrams per deciliter to compensate for the fact that most people are not fasting when they have blood work done. The peak phosphate levels occur at 4 a.m., which is why it's so important when you're evaluating someone to have an early morning sample. And because, again, of the intracellular shifts that can occur with eating, why it's important to be fasting. And nadir phosphate levels occur at approximately in late morning. So most Western diets are quite replete in phosphate, with there being approximately 2.5 grams of phosphate that are presented to the intestine daily, with absorption primarily occurring in the small intestine and the ileum and jejunum, respectively, and that phosphate absorption occurring independent of vitamin D. The phosphate absorption And we absorb about 60 to 80% of the phosphate that we consume, occurring by both paracellular and transcellular mechanisms. It's really only in the presence of profound dietary phosphate deprivation or hypophosphatemia that the activated form of vitamin D, 125 dihydroxyvitamin D or calcitriol is needed to increase absorption of phosphate from the gut. All of that phosphate that's absorbed is then presented to the proximal tubules and is filtered in and comes out in that glomerular filtrate. And it's only because of active reabsorption of that glomerular filtrate in the proximal tubules that we all are not profoundly hypophosphatemic based on, again, normal phosphate circulation. There are very small losses of phosphate in other bodily fluids, but really it's our ability to reabsorb phosphate in the kidney, in the proximal tubule, prevents us from being hypophosphatemic. And it's at the level of the proximal tubule that both parathyroid hormone and fibroblast growth factor 23 promote renal phosphate wasting. It's been established that when you have certain physiologic or other states, the body can either decrease or increase urinary phosphate excretion. So again, in the setting of low dietary phosphate intake or growth hormone, insulin, or thyroid hormone, there is a decrease in urinary phosphate excretion. And in the setting of elevated dietary phosphate, the phosphaturic hormones, steroids, acidosis, volume expansion, and FGF23, there's increased phosphate excretion at the kidney. In addition to defending against hypophosphatemia by suppressing urinary phosphate excretion, the body attempts to lower parathyroid hormone levels by increasing the degradation of the protein to which PTH is circulates, and to lower PTH levels, and the other mitigating physiologic change that occurs with hypophosphatemia is an increase in 125 dihydroxyvitamin D. So in a patient who has low circulating serum phosphate, they should have, if everything is working properly, a low urinary phosphate, a low or normal parathyroid hormone, and an elevated 125 dihydroxyvitamin D. To understand urinary phosphate excretion, you must calculate the fractional excretion of phosphate, which requires fasting at early morning, and then what's called a double voided urine sample, which means that we ask our patients to empty their bladders at home, drink a large glass of water, and then come in to produce a fresh sample. And again, if your kidneys are working normally and your serum phosphate is low, and I would say really someone whose serum phosphate is under 2, then we should see urinary phosphate excretion going to 0%. The tubular reabsorption of phosphate is just the 100% minus the FePO4. One of the reasons that I'm drawn to hypophosphatemia is that you can really put the differential diagnoses for low serum phosphate into 3 buckets. Internal redistribution, renal causes of low serum phosphate, or gut causes of low serum phosphate. And each of those 3 buckets is associated with a certain FePO4, a certain fractional excretion of phosphate. So if it is an internal redistribution or a gut cause of your low serum phosphate, the fractional excretion of phosphate should be low, again, in that less than 5% range. And then if you assess a patient, they have a low serum phosphate and their fractional excretion of phosphate is elevated. And by that, I would argue 5% or more, because you'll see that for patients, the two cases, it was even more profound. When you see an elevated urinary phosphate excretion, anticipate that that's pointing you towards a renal etiology of the low serum phosphate. With regard to internal redistribution, again, which we might suspect when fractional excretion of phosphate is low, any kind of refeeding, whether that's normal eating, malnutrition, or anorexia nervosa that is being treated, patients who are malnourished related to diabetic ketoacidosis or malnutrition related to alcohol use disorder, anytime patients are refed, they can have, again, this intracellular push of their serum phosphate. Respiratory alkalosis also leads to intracellular shifts and any kind of increase in cell turnover, whether for normal or restorative purposes. For example, in a patient who's post-parathyroid surgery and has developed hungry bone, or in a patient who is being treated for vitamin D deficiency, you can see lower serum phosphate there, or in pathologic causes in patients who have metastases that are resulting in increased pathologic cell production. With regard to renal causes of phosphate wasting in a patient who has, again, an elevated urinary phosphate excretion, our buckets can be related to parathyroid hormone, related to FGF23, related to sodium phosphate cotransporter disorders. And then I'm going to go forward for a second. It can also fall under the categories of tubular dysfunction. So Fanconi syndrome of any etiology can lead to renal phosphate wasting with elevated FePO4. Dense disease, which is a disorder of chloride channels, magnesium deficiency, they can all cause Fanconi syndrome. A patient, any kind of increased forward flow that can occur with either hyperglycemia or a volume expansion of any kind can do that, because essentially the ability of the proximal tubule is overwhelmed and that reabsorption of phosphate cannot occur. I want to point out that for alcohol use disorder, it actually can cause low serum phosphate via two mechanisms, either by the refeeding syndrome related to malnutrition that I mentioned, or alcohol use disorder can lead to tubular dysfunction and Fanconi syndrome. When someone is abstinent for about 2 to 3 weeks, the tubular dysfunction resolves. With regard to the disorders on this slide, again, any elevation in parathyroid hormone will lead to a removal of sodium phosphate cotransporters from the brush border of the proximal tubules, and then lead to this elevated urinary phosphate. That is also the mechanism by which FGF23, and I'll talk a bit more about these disorders in a few slides coming up. FGF23 not only can acutely lead to the removal of the sodium phosphate cotransporter from the brush border membrane, but it can also chronically lead to decreased transcription of that same sodium phosphate cotransporter. After, and I would say really since 2000, our understanding from a genetic perspective of these disorders has really expanded. There was recognition that there are genetic mutations that can affect the NaPi2c cotransporter that result in a clinical syndrome as well. And finally, with regard to GI causes of hypophosphatemia, and again, alcoholism or alcohol use disorders. Here again, anytime there is low protein intake, there can be the just in a lack of substrate. If someone is not consuming protein, that can lead to hypophosphatemia. Usually it has to be pretty profound, again, because there's such an overabundance in phosphate in most diets. And now that we use H2 blockers and proton pump inhibitors, antacid use as a cause of hypophosphatemia is less prevalent, but has happened in the past. And you have to have pretty significant forward flow from diarrhea or poor absorption from steatorrhea, again, to prevent absorption at the GI level. Medications with respect to the medications that can cause hypophosphatemia fall under these buckets as well. So there are medications that cause redistribution of phosphate intracellularly. There are medications that can impact the wasting of phosphate by the kidney. Tenofovir, as one of our HIV medications, has been known to do that. Second generation tenofovir medicines, which have been modified, are less likely to do that. And then again, I've mentioned what can happen at the level of the gut, and the imatinib falls under the other category. So with regard to FGF23, fibroblast growth factor 23, there was always this sense that there was a hormone that had not been identified. I'm really delighted to see Dr. Michael Collins on the call, who is, of course, one of the leaders in this space. But there was an appreciation that there were two inherited forms of rickets and two inherited forms of hypophosphatemia and one acquired form of hypophosphatemia, the inherited ones being ADHR and X-linked hypophosphatemia, respectively, and the acquired being tumor-induced osteomalacia, which was also previously called oncogenic osteomalacia, that had very similar biochemical and biochemical as well as physical manifestations. Patients with these disorders presented with weakness and bone pain, depending on the age of presentation. If it was prior to the closing of growth plates, they presented with rickets. If it occurred after puberty, they presented with osteomalacia. But in both the inherited and the acquired forms, there were increased fractures. And these patients have lower or low serum phosphate, elevated renal phosphate wasting, and low or inappropriately normal 125 dihydroxyvitamin D levels. So as I mentioned, again, given the physiology that exists, patients should have very elevated 125D if their serum phosphate is low. So with regard to some of the physical manifestations, this cartoon shows some of them here, and this could be rickets related to phosphate or calcium disorders or vitamin D disorders. But patients can have protruding foreheads. They can have, again, the pectus excavatum, kyphosis related to fractures, protruding abdomen related to fractures. And then, of course, the lower extremity changes that are impacted by us for people who are able to stand. And those are shown pretty significantly in these images of children who either have genu valgum, genu varum, or this windswept deformity. So really heartbreaking images. For the patients who have tumor-induced osteomalacia, which again is a paraneoplastic syndrome, they can present with imaging that almost appears to be metastatic disease. So this is a patient with multiple compression fractures as captured by this increased uptake in their diphosphonate scan. that relate, whole body scan that relates to compression fractures, as also shown here on MRI. And then these hot spots that are present in the ribs, as well as here on the distal femur, as well as the proximal tibia that's shown again here in MRI, which are actually these insufficiency fractures, looser zones. And I will say that I always find the definition of them a little bit challenging, but they again are thought to possibly be areas where an overlying small blood vessel contributes to the insufficiency fracture in the setting again of the osteomalacia. So the case was really cracked about FGF23 through studying patients with autosomal dominant hypophosphatemic rickets, which is the rarest of these disorders, performing linkage analysis in these patients and identifying a mutation on chromosome 12, which ultimately was recognized to prevent the degradation of FGF23. Patients with X-linked hypophosphatemia have multiple mutations that impact FGF23 physiology. There's a murine model of X-linked hypophosphatemia called the Hype mouse that's really advanced a lot of understanding. And then ultimately, it was through the recognition that in most, but not all patients with tumor-induced osteomalacia, they have mesenchymal tumors that overproduce FGF23. When you're able to identify the location of the tumor and resect, the phosphate and vitamin D abnormalities resolve within hours post-surgically and patients improve. After, again, identifying FGF23 as being common to those three sort of foundational disorders, it was recognized that patients with Macuna Albright syndrome, approximately 80% of whom have a low phosphate, that in biopsies from their bones, they showed that in areas of fibrous dysplasia in particular, that the bone was over, but not only, overproducing FGF23, which led to a paradigm shift in thinking of bone as an endocrine gland. And then after FGF23 was recognized through, again, additional genetic work, there was an appreciation that factors which are part of FGF23 physiology, as well as FGF23 itself, can result in an autosomal recessive hypophosphatemic rickets. So these are, again, one of the key early studies showing that patients with tumor-induced osteomalacia, the majority of whom, similar to patients with X-linked hypophosphatemia, have FGF23 levels that are far higher than the normal range. And, you know, notably, there are patients with XLH who don't have elevated FGF23. So there is still ongoing investigation of other phosphatonins, but that with surgery, as shown by the patients who have the dotted lines, most go from having elevated to normal FGF23 levels. FGF23 is a 225 amino acid. The mutation that is present in ADHR, autosomal dominant hypophosphatemic rickets, results in a change at amino acids 176 to 179 that prevents the cleavage of what is thought to be the active peptide, so that in someone with wild type, they will have in circulation both intact peptide as well as fragments that are thought mostly to be inactive. But in patients with ADHR, they only have the intact peptide. Our initial assays that were available to measure FGF23 had detection and capture antibodies distal to that cleavage site. So those first generation assays were measuring both the intact as well as the C-peptide fragments. And then subsequent assays are on either side of that cleavage point and thus can measure intact peptide only. I mentioned some of this physiology to you already, that through studying animals who were administered FGF23, whether they had their parathyroid glands intact or not. There was an observation of the acute changes on the sodium phosphate cotransporter, but that chronic administration of FGF23 results in the decrease in transcription of NAPI, with there being those two acts leading to an increase in urinary phosphate. But then FGF23 has a two-fold harm to the vitamin D physiology. It both suppresses 1-alpha hydroxylase, which is needed, of course, to produce the active vitamin D form, 125 dihydroxyvitamin D. And FGF23 stimulates 24-hydroxylase, which also degrades a 125D. So you have a low 125D, and together the high urinary phosphate as well as the low 125D leads to the low serum phosphate. After identifying the role of FGF23 in physiology, it was recognized through knocking out the FGF23 in a mouse model that you were able to create the opposite. So in the absence of FGF23, urinary phosphate is quite low, 125D is quite high. And in fact, animals die from hypercalcemia, and there is a bone phenotype. And what was observed was in the FGF23 knockout mouse that hypercalcemia and elevated serum phosphate leads to ectopic calcium phosphate deposits. There are patients then that were identified to have tumoral calcinosis that was secondary to mutations in FGF23, but then also that there were mutations in gallant, which is a glycosidase, which is needed for FGF23 processing, as well as mutations in klotho, which is a critical co-receptor for FGF23 that resulted in a clinical tumoral calcinosis. Picture again, these patients would have elevated serum phosphate. As I mentioned, FGF23 is made in the bone through investigations done through the ADHR consortium and others. It was shown that there is not FGF23 made in the kidney. So I've spent a few years studying FGF23 in health, and there really has been quite the expansion of FGF23 physiology since 2000, similar to how the sort of all the major leaps in our understanding. After generating the FGF23 knockout mouse, there was an appreciation that the klotho knockout mouse had very similar physiology to the FGF23 knockout mouse, and there were also appreciations that klotho deficiency leads to tumoral calcinosis and klotho excess leads to a hypophosphatemic rickets. So with regard to the physiology, it's known that dietary phosphate, regular vitamin D, as well as calcitriol all stimulate FGF23, as can low iron. And that was one of the, that was the physiology that Dr. Econs manipulated, and that's treatment of iron, treatment of patients with ADHR with iron. And I think there's ongoing investigation in terms of how these other factors and entities, where they dock into FGF23 signaling. And then this was the key finding through the Indiana group, Drs. Immel and White, that in patients with ADHR, in the setting of iron deficiency, they have elevated FGF23 levels, and because but in patients who have our ability to detect this was really dependent on the assay. So in the assay with the C-terminal, which is measuring again both intact peptide as well as fragments versus the intact FGF23, where you would only measure intact peptide but not fragments, you saw this relationship present of low iron and elevated FGF23 in both the patients with ADHR, irrespective of which kind of assay you use. But in patients who were wild-type controls, you only saw elevated FGF23 in iron deficiency, where we could actually measure the peptides, the C peptides, but in the assay where you were only measuring the intact FGF23, that relationship was not present. So when we're evaluating patients with hypophosphatemia, keep in mind that the manifestations of hypophosphatemia, while typically I think of muscle manifestations and myopathy in particular, it can really cover any of these, from vague weakness to death. And when we're thinking about treatment, I would assume that the more serious manifestations would really be associated with lower serum phosphate in the 1 milligram per deciliter range. But in a patient who is having arrhythmias or is ventilator dependent and their circulating phosphate is 1 milligram per deciliter, you should worry that the hypophosphatemia is contributing. As I said, most patients we focus on weakness, fatigue, and their bone symptoms, but these are some of the other symptoms that can occur with profound, persistent hypophosphatemia. So with regard to the evaluation, taking a very detailed family history helps to unpack if someone may have a congenital or genetic form of hypophosphatemia. I mentioned earlier medications and the different ways that alcohol use disorder can contribute. The physical exam might make you lean towards some of the either inherited forms or more profound hypophosphatemia. And then testing should cover the major categories that I mentioned already. Being able to calculate their FePO4, being able to assess for hyperparathyroidism, whether primary, secondary, tertiary, assessing for their 125D, given again, if it's low or inappropriately normal, it might push you more towards an FGF23 etiology, the urinary studies to assess for Fanconi syndrome, and then finally being able to measure FGF23. So with regard to genetic testing, this I would argue, and I'd love to hear how you approach your genetic testing in patients with hypophosphatemia, should be considered in patients who have had symptoms since either childhood or young adult, remembering that for some of the inherited forms, there can be later penetrance. If someone has a family history of hypophosphatemia or has Rickets, again, which argues that they're having a presentation that precedes the closing of their growth plates. And then finally, in someone who has ongoing family planning concerns and is hoping to, if knowledge of a genetic form of hypophosphatemic Rickets, if that would change how they approach their family planning. So with that, I'm going to pause. We ended a little bit early, which is always great. And I'd love to hear your questions. I've left out, a good amount because as we discuss the cases, we're going to talk a lot more about again, how we approach the evaluation as well as the treatment. But I'd love to either have you unmute or put questions in the chat.